So I'm a physician at Hershey Medical Center, and I see patients with eating disorders. So we're going to talk about eating disorders today for your class. Through the magic of PowerPoint, we're going to have all these different slides. I guess it's going to be eventually posted on, I guess, is it Angel? You guys use Angel? So that you can look at it. And I like to use a lot of case examples when I talk, although the cases are a little bit of them out. Let's see if this works. It doesn't. Oh, there we go. So in terms of this case example, this was a 22-year-old woman that I saw a year or so ago, and she was a college student at one of the local universities. And she was a track star. And she was running what came to school in the fall to run cross-country. And when she arrived for her initial training, the trainer and the coach asked her to not participate that year because she was really looked too ill. And they thought that she looked malnourished and said she really needed to go to the student health center. She went to the student health center for evaluation. We saw her, and she was immediately admitted to the intensive care unit for treatment. She had had a history of severe restriction of her food intake. She had lost more than 50 pounds in about 6 months. She had been seen by her doctor that summer and who noted her weight loss, but asked her to eat better, but sent her off to school and cleared her to return to track. She had significant exercise with running even the day that she was admitted. So what happened was she was seen on a Thursday night and sent home by the track and cross-country team. She did her usual 5-mile run in the morning, and then she went to the student health center. She did not use laxatives or vomit, but she did use diet pills, and she had secondary amenorrhea. Does anybody know what that is? What does that mean? She had lost her menstrual periods. Amenorrhea is loss of menstrual periods, so she wasn't having her periods. She was 5'11". She weighed less than 110 pounds. Her pulse rate was 32 beats per minute. Usual pulse rate would be 60, 70, 80 beats per minute. Her blood pressure was 88/56, which is very low. She had a low sodium, a low potassium, a low phosphate. She had abnormal kidney function tests, abnormal liver function tests. She had an abnormal EKG and an abnormal echocardiogram. Very severe findings. You don't have to worry about the medical details. And she had run 5 miles that morning. She did well in the intensive care unit. She was treated with intravenous fluids and electrolytes. Started to eat a little bit better. She was noted to be exercising on a monitor in the intensive care unit, just doing some toning and some crunches. And that was discouraged. She was from South Carolina, and her parents came up and took her home to a treatment facility in South Carolina. But you can see how very seriously medically ill the patients can get. The diagnostic criteria are set in a document called DSM-4. That's the Diagnostic and Statistical Manual of Mental Disorders. This big encyclopedic book, which is wonderful bedside reading, which basically goes through all the different psychiatric disorders, and that's where the criteria are set by the psychiatrist. And they're very useful, although we don't keep them too strictly in determining who's going to be treated and who's not going to be treated. So these are the DSM-4 criteria. Anorexia is a refusal to maintain a normal weight for height, which leads to a weight which is less than 85% expected. So think of it this way. You're 15% or more underneath your expected body weight. It can classically include weight loss, but for younger kids around puberty, they might just not gain any weight as they have their pubertal growth spurt. Have you learned about the pubertal growth spurt? You remember pubertal growth spurt, you grow a lot when you're a teenager, but if you don't gain any weight, if you're the same weight as you were when you were 12, but you've grown 5 inches, then it's going to lead to a disparity between height and weight. Does that make sense? Okay. There are 2 subtypes. There's the classic patient who just restricts and doesn't eat, but there are also patients who binge and purge, which often means vomiting, not only, but they're underweight. And many adolescents don't fulfill all this criteria, and they're sort of subclinical. Can you go back one? This thing doesn't go back. Okay, go for it. Repeat it. Now, this young person was 16 years old, and she was on the gastroenterology service. And she had intractable vomiting. She was just vomiting a lot. And they did all sorts of different tests. Eventually took out her gallbladder. And eventually we were consulted, and she was bulimic. She was making herself vomit. She also had vomiting that just happened. She was using sex without birth control. She had chlamydia and herpes. She used drugs, depressed, and she was cutting herself. Welcome to my world. The hallmark of bulimia is these recurrent episodes of binging, followed by some inappropriate compensatory behavior. The binges classically will occur twice a week for 3 months. And they're characterized by eating a large amount of food over a short period of time with a feeling of lack of control over the eating. Now, what exactly a binge is really not specifically defined. So, classically it's going to be a large amount of food, a whole bag of potato chips, a bag of cookies, half gallon of ice cream in a half an hour. But it doesn't have to be that much. It can just be a lot. But we had a young person who came in and said, Dr. Levine, I binged terribly last night. I said, Tara, what did you eat? She said, I had a turkey sandwich. That's kind of a meal. It's not a binge. So if you have a turkey sandwich, that's not what I would consider a binge. That's sort of what we eat for lunch or for dinner. But eat a large amount of food with a feeling of lack of control of the eating. And then with some type of compensatory behavior. Now, classically, that's vomiting, making themselves vomit. But it could be laxatives, diuretics, making them urinate a lot. It can be exercise. It can be lots of different things. And again, they have an over-concern with weight and body shape. That's true for anorexia as well. They are preoccupied with the issues of food and weight. They are obsessed with the issues of food and weight. And that's the hallmark of eating disorders in general. Classically, again, it must occur twice a week for 3 months, but it could be various different things. There are classically those with bulimia who purge, and there are others who might fast or use exercise. So they're not purging, not vomiting, they're using exercise. So that can be bulimia too. That would mean, we had one young woman that would do a half an hour on the treadmill and a half an hour of weights and a 5-mile run with each meal. So, you do that 3 times a day, you're not getting a lot done because it takes a couple hours. So the exercise purging behavior. And then if you can't really figure out whether they're anorectic or bulimic, you can say they have eating disorder, not otherwise specified. We'll call that EDNOS, which is just a grab bag clinical criteria, clinical classification, which doesn't mean that much, but they have some eating disorder behavior. If you're interested, there are some controversies about these criteria. In the next 5 years or so, they'll be coming up with sort of a new classification. For instance, that cutoff weight of 15%. Why does it have to be 15%? What if it's 12% or something like that? Classically, patients with anorexia will have loss of menstrual periods, amenorrhea, but they don't all. Some women continue to have their periods. What's different about them? But they still have anorexia. These subtypes. We also see patients who flip from one category to the other. So it's not like you're in a category and you've joined your sorority or your fraternity or something. People flip from categories. And binge eating disorder. We see a lot of patients who just binge. They don't purge. And that really isn't a classification now, but it probably will be. And then what is the role of this eating disorder not otherwise specified? It's kind of just a grab bag. So there are a lot of different things that will happen. The way they do these criteria is basically you take about 25 psychiatrists, you lock them in a room and say, we'll feed you when you come up with a new criteria. I mean, it's nothing magical. They just different experts will come together and say, well, it's changed a little bit. We'll have some new criteria. Eating disorders have certainly increased over the last 30 years. The prevalence of anorexia is around 1 in 120 adolescent young women, so a touch less than 1%. Primarily females, about 10-to-1 ratio. And the peak ages of anorexia would be around 13, 14, especially around puberty, and then around 18, 19 or so. Bulimia is more common in the older teens, so it's less likely to see a 13-year-old with bulimia, more likely to see 18, 19, 20-year-olds with bulimia. Again, primarily females, but we do see males. And classically, there are certain ethnic groups and demographic groups, but it can be any ethnic group and any demographic group. In other countries, this has been studied, and they certainly see eating disorders in other countries. Western Europe, see a lot of eating disorders. Australia and New Zealand. But even other countries where certain cities have been more modernized or westernized, so Hong Kong, Delhi, Tokyo, lots of eating disorders, less likely in a rural village or something. But these statistics underestimate the prevalence of disturbed body image in teens. 2/3 of girls at 14 years of age are unhappy with their weight or body shape. That's completely irrespective of whether they are overweight, underweight, or normal weight. They're unhappy with their weight and body shape. They actually did another study recently, similar questions, to a group of 40-year-old women. And 2/3 were unhappy with their weight and body shape. So you'd like to think that as people get older and mature that they wouldn't be so concerned, but it was exactly the same. It's kind of ubiquitous in our society. Over half of teenage girls at 14 have been on a diet. Doesn't mean they all have eating disorders, but they've been on a diet. They're restricting their food intake to lose weight. Many will use unhealthy weight control methods, fasting and diet pills. And these, as I mentioned sort of before, these tend to cluster in the same kids. So if you see kids who might have drug problems or depression, eating disorders, they kind of go together sometimes. I mentioned a couple things about college-stage kids. High incidence of eating disorder symptoms among college women. And a high incidence of eating disorders on campus. Bulimia is certainly more common on campus than anorexia. Actually, the study showed that the most common diagnosis on college campus was eating disorder not otherwise specified. That kind of makes sense because it's not quite as clinically severe. If they're that clinically severe, often you're not in school because the school, in my experience, is that if you're really sick, they ask you to take a leave of absence and come see us and get back. A lot of controversy about prevention programs. There was a recent study which showed a positive effect, that's the International Journal of Eating Disorders, on a prevention program. But, you know, the question is, are you having a long-term effect? So they'll have some program about nutrition, about the media, and then look 6 months later and you've made a lot of changes. But if you look a year or two later, people's attitudes kind of fall back to where they were before. So it's hard to have a lasting impact. They've done prevention programs for middle-aged, little girls, middle-aged students, and high school students, but also college. I want to mention the female athlete triad. Have you heard that term before? Female athlete triad. That is disordered eating. Not necessarily a psychiatric clinical eating disorder, but disordered eating, loss of menstrual periods, that's amenorrhea, and then the risk of osteoporosis and brittle bones. It is very common for elite women athletes, college-age athletes, to not be having their menstrual period. But it isn't normal for college female athletes not to be having their period. I know it's common, but it shows that their training and their nutrition are out of balance, and it's putting them at risk, we'll go into this later, for osteoporosis and brittle bones. And there was a recent study correlating dieting and binging with alcohol abuse among female college students as well. The etiology is a whole bunch of different factors. There's clearly a biological etiology. There is a genetic role in terms of the development of eating disorders. There are psychological factors and cultural factors. Have you heard this before about serotonin dysregulation or neuroendocrine dysregulation? Serotonin is a chemical in the nervous system, a neurotransmitter, which can be out of balance with many psychiatric conditions, depression, anxiety, obsessive compulsive disorders, as well as eating disorders. And the tendency towards having imbalance of serotonin would be somewhat inherited, the way many things are inherited. Psychological issues, well, individual problems, but family issues as well. Patients with anorexia tend to have a low self-esteem with a pervasive sense of ineffectiveness. They do not feel that they're effective in terms of that they do. Yet they're very perfectionistic. So they have very high standards, but they never feel they live up to their standards. That's a very tough combination. I saw a girl today, high school student, #1 in her class, and I said, how's school going? She said, I'm not really doing very well. I said, what happened? She said, well, I got a 99 in geometry, because she didn't get 100 in geometry. She got a 98 in something, 99, all the rest of the grades are 100, but if they're not all the hundreds, then she's failed as far as she's concerned. That type of perfectionism. Patients with anorexia tend to be depressed, anxious, obsessive. Patients with bulimia tend to have particular problems with impulse control. Thus the example of the girl having sex using drugs with bulimia. Not always, but tend to have more problems with impulse control. So you're going to see more type of risk-taking behavior. We actually did a study on cutting and even body piercing with bulimia versus anorexia, and more patients with bulimia had multiple piercings and tattoos than patients with anorexia. Negative body image, the low self-esteem, leads to a need to conform to society's standards. Many eating disorders share this distinctive core pathology of judging their self-worth by their weight and their appearance. That's how and if they've eaten too much and they've gained a pound, then they think terribly of it. So their self-worth is determined by their appearance. Family dynamics are very important, and there is an association with sexual abuse and trauma, assault and rape, but it's very important to understand that not every patient who has an eating disorder has been traumatized like that, and not every patient who has sexual abuse has an eating disorder, but there is an association. Cultural influences, obviously, in terms of the emphasis on thinness in our society, the models and the magazines, an increase in nutrition and fitness articles. The average model is about 23% underweight, which would be in the anorectic range. Some exercise issues, particularly women in gymnastics, particularly women who are in sports where their appearance is part of the scoring. So some types of dance, figure skating, gymnastics, less likely with basketball. Males, particularly with wrestling, and interesting bodybuilding. You'd think it wouldn't be, but it is, because they get very focused on their appearance. Warning signs, weight loss, obviously. Very poor eating, constipation. Feeling cold. You know, we're all warm-blooded, so you keep your body temperature up, and if you go outside in the cold weather, but to keep your body temperature up takes energy. And if you don't have enough energy, you're cold. Fatigue, depression, loss of menstrual periods, I mentioned, laxatives, purging, swelling of their salivary glands because of the purging, calluses in the knuckles from sticking their fingers down their mouth, etc. Yes?
What do you mean by withdrawal?
Yeah, that's a good question. I usually mean withdrawal from getting isolated, withdrawal from their friends, you know, not doing the usual things that they like to do. That's what I meant by that.
Okay.
Yeah, not like a drug withdrawal. Good question. I should probably clarify that in the slide. So when I see a patient, you know, I'm going to assess their history and their physical, assess their eating behavior. We have to do the physical exam very carefully because they can, you know, try to do things, wear a lot of clothes or things to make weight. We've had people drink, you know, 2 liters of Diet Coke before they come to make weight. Lots of different things to try to make weight. And we're looking for the physical sequelae of the diseases and then other kind of conditions. The differential diagnosis, meaning when I see a patient, what am I thinking? What else could it be? A number of different things. Certain hormonal conditions, imbalances of the thyroid or the adrenal glands, stomach conditions, inflammatory bowel disease, Crohn's disease, things like that. That could mimic an eating disorder. I had a patient who was vomiting and had weight loss because she had a brain tumor. You don't want to miss that. Chronic infections, systemic lupus, certain things. So we think of these other things when I see a patient, although almost always they have what we think they have. But occasionally, there's something different. And so we do some blood tests and do our physical examination to make sure that we're not missing something, that they don't have some other type of imbalance. But we do also see patients with chronic illnesses who have an eating disorder. And the classic for that is diabetes mellitus, diabetes. But they have diabetes, but they develop an eating disorder because of thinking a lot about food and weight. You study diabetes in your nutrition? Well, I'm going to spend some time. I'm not going to spend as much time as I might thought because I want to have time for questions, but about the medical issues. These are serious medical problems. They affect every organ of the body. There is a certain mortality associated with anorexia. Some people die. And many of the complications are reversible if the patient does better, but some are irreversible. Causes of death would be suicide, severe electrolyte disturbances. That means sodium, potassium, chloride, fluids, things like that. And then arrhythmias, that's abnormal heart rhythms because of the electrolyte problems. Arrhythmias means an abnormal heart rhythm. This is an important point. The patients with anorexia have a slow metabolism. They have an abnormal metabolism. Think of it this way. Their body is reacting to starvation and malnutrition. Their body is in famine mode. The way your body will react to a famine is by slowing your metabolism to conserve energy. It's like you have a thermostat in the hypothalamus and the gland in your brain, which regulates energy balance. And your body can sense this imbalance of energy and slows your metabolism to conserve energy. So everything slows down. Your heart rate goes down, your blood pressure goes down, women lose their menstrual periods, and this is all a physiological adaptation to starvation. It's no different than if you went to a famine zone and were seeing patients there. Fat body mass is reduced, and lean body mass is reduced. That means that their muscle mass is reduced. They literally take their muscle tissue break down muscle into amino acids. Have you heard that term before? Amino acids. And there are biochemical pathways that turn amino acids into glucose. So that's why if you look at patients with anorexia, their muscles have shrunk, because they are literally eating up their muscle tissue. Not physically, but their body is eating up their muscle tissue. It's called auto-cannibalization. And it's providing glucose to keep their heart and their brain going. Got it? Now this young woman had anorexia with purging, so she wouldn't eat, but if she ate, she'd throw up. And she had a long history of symptoms. She presented to the emergency room with syncope, that's fainting, she fainted. And her potassium was 1.4. That's like close to death. Usual potassium would be 3.5 to 4.5. That's probably the lowest we've seen. The ER was like, oh my God. She actually has done very well. She was treated for a number of years, and she is now working. She's married, she has 2 kids, and she's doing great, but it took years of treatment. So patients with bulimia or anorexia with purging can have problems with their fluids and electrolytes because of the vomiting. Different fluids they lose and different electrolytes that they lose. Also, if you weigh yourself 20 times a day, you realize that if you have a drink of water, you gain weight. So they won't drink because they don't want to, quote unquote, gain weight because they're weighing themselves so often. So they can get quite dehydrated that way. We've also had patients with hypoglycemia. Do you know what that is? What's that? Low blood sugar. So they've had hypoglycemia with seizures because of hypoglycemia because they don't get enough energy. Now this young woman we still see, and she had the classic pattern of bulimia, the restricting, binging, purging pattern of bulimia. She wouldn't eat very much during the whole day. She'd come home later and then she'd overeat, and then she'd throw up. And that would happen several times. She was depressed. She was cutting herself, used drugs, she had abdominal pain, sometimes she'd throw up blood, and she would have involuntary vomiting. So because of the damage to her system, if she kind of burped, she'd be, like in class. So turn around. She was 5'4", she weighed 139 pounds. The important point is that women with bulimia are usually very normal weight. Sometimes a little overweight, sometimes a little underweight, but pretty normal weight. And so otherwise you can't tell. So it can be very, very hidden. You won't know unless you sort of see their behavior. She had an endoscopy, which means they looked at her esophagus, and she had an irritation of her esophagus. She was treated with all sorts of different medicines, and she's done better, but she's still in treatment. This young woman had all the signs of anorexia. She was 5'9", she weighed 94 pounds. And then she started to eat, and then she started to overeat. So she started to binge. And she would purge with laxatives. She wouldn't vomit, she would take laxatives. Oop. Now I figured out how to go back. Now I won't go forward. All right. She gained 60 pounds in 6 weeks from binging. She had abdominal pain, don't wonder. And because she damaged her bowel with the laxatives, she required all sorts of different treatments to get her to go to the bathroom. She's actually done all too. So the stomach complications depend upon what's going on. If you don't eat very much, your gastrointestinal motility slows down. Your stomach and intestines kind of slow down. And so then if you eat, you get full fast. You do get full fast. And so they get an early satiety. They get full fast. They get kind of constipated because if you don't eat, you don't poop. So they get constipated. You know, this is very interesting. Okay. If you take lots of laxatives, you can damage the muscle nerve complex to your bowel, and you can get what's called a cathartic colon. And then you don't go to the bathroom at all. Like someone will come in and they'll say, well, I went to the bathroom in September. You know, it's like 2-3 months when they went to the bathroom. And they're very uncomfortable, and they can damage their bowels. We also have problems from the vomiting, of course. You can get I mentioned involuntary vomiting. You have ulcers, reflux. We had one patient who ruptured her esophagus into her chest. That's not a good thing to do. She lived, but it was medically very serious. We don't have to worry about it. We use all sorts of medicines to treat that. Yeah, different histamine. It's a different histamine. There's histamine receptors in your stomach. Now, for cardiac, this young woman, the little girl, 12 years old, She was 5'4", she weighed 72 pounds, and her pulse when she was admitted was 18 beats per minute. That was her pulse rate. Take your pulse rate now. Mine's a little high because I'm standing in front of you, but your pulse rate might be 60 or 70. Hers was 18. You could go have a cup of coffee between your pulse. I mean, it was a long time, and that's from that malnutrition. And she was in the intensive care unit. She did great. She had EKG abnormalities. She had fluid around her heart, but 6 months, a year later, she was fine. This young woman had shrunk her left ventricle by a third. Not only did she have auto-cannibalization of her skeletal muscle, she had auto-cannibalization of her heart muscle. Her heart was this little bitty thing because she shrunk her heart because of malnutrition. Also did well. I mentioned the low heart rate and the low blood pressure. You can also have all sorts of EKG abnormalities. Now, in terms of physicians, if you take this patient who's really malnourished with a sort of abnormal heart, and you give them too much fluid, you can put them into CHF, that's congestive heart failure. This young woman, you won't know this, but she presented with muscle weakness and shortness of breath. And she had an abnormal heart, plus she was so weak she couldn't get out of a chair. Anybody know what she was doing to cause that? It'd be tough. Most of the medical students don't know either. She was using Ipecac to vomit. Ipecac is what they used to have for little kids to vomit. If they overdose, they actually don't recommend that anymore. But she'd go to the drugstore and use Ipecac to vomit, which damages your muscle tissue. She also lived through this, but it was very, very difficult. Over-the-counter diet pills. We just sent a girl to the emergency room today from taking like 20 or 30 of the diet pills, and she, we were worried about cardiac ischemia and a heart attack. She's in the emergency room as we speak because of the abuse of the over-the-counter diet pills. Very, very dangerous. There were reported strokes and heart attacks from that. Now, I mentioned the alterations in the neurotransmitter levels. That plays a role in the etiology of the conditions associated with the comorbidities. That means the other type of conditions, depression and things like that. But it's important to note in severe anorexia, not mild patients, but severe patients, they have abnormal CAT scans of their brains. They have cerebral atrophy. They have shrunk their brains due to malnutrition. And it's not clear that that completely gets better. If you look a year later, it's improved, but it might not be 100% better. And that's not every patient. That's the most severe patients. But patients we have very sick in the hospital with anorexia, if you do these CT and MRI scans, they've shrunk their brains, which is not a good thing to do. We're doing good. This young woman presented at age 12, and she's someone who never really lost weight, but she never gained weight. I mean, she was the same weight at 12 as she was when she was 9. And she got treatment, and she's perfectly normal. She's in college, normal weight, she looks fine. However, she has not reached her genetic potential for height. She's about 5'1", 5'2", which is normal, but her mother is like 5'7", 5'8". Her father's 5'10", 5'11". So genetically, you'd expect her to be taller, but she kind of missed her growth spurt. So she ends up being, 5'1". I have girls who are 4'9", 4'10", 4'11". They never reach 5 feet because they sort of skipped their growth spurt because they didn't eat during their entire adolescence. She also had amenorrhea, loss of menstrual periods. She has osteopenia, which is brittle bones, and she's had 5 stress fractures. And that's kind of one of the irreversible legacies of her adolescence, of anorexia. This is complicated, but the loss of menstrual periods is due to dysfunction of the hypothalamic. Do you know what that is? Gland in the brain, pituitary, lower gland in the brain, and the ovaries. So it's the whole system which is sort of out of balance. There's nothing inherently wrong with their ovaries. It's the hormonal balance is out of whack. Well, that's an important. Let's see if we can go back. No, can you go back? We use resumption of menses as a marker for recovery, meaning that if I have a woman who's 5'8", and weighs 80 pounds, if I tell her that the average weight for her would probably be 130 to 145 pounds, she's going to throw up on me. I mean, she's not going to listen to that. So I say, you know what, I'd like you to get your periods back. And if you get your periods back, then we're in pretty good shape. Now, I know from different studies that usually women will get their menstrual periods when they're around 90% of their ideal body weight. We can go over how that's calculated. With around 18 to 20% body fat. For women to have menses, you need about 18 to 20% body fat. So if you have a woman athlete who proudly announces that she has 8 or 10 or 12% body fat, she's probably not having her menstrual periods, and then she's out of balance. Women naturally have to have a little bit more adipose tissue. We don't like to say fat because it's like swearing, but a little more adipose tissue to get their menstrual periods and to have their body be in balance. This young woman is in college, about 20, 21 years old. She had all these medical complications, and she has osteoporosis, severe osteoporosis at 20. She has the bone density of your grandmother at age 20. This is really complicated, so well, that's not good. So do you want me to go over a lot about osteoporosis, or not really? A lot about osteoporosis, or skip through? Okay. Skip through. Did you be tested on? There are 3 phases to bone mineral development. There's growth, which is where you all are, consolidation, and senescence. That's where I am, for many reasons. Which means you have a growing period, you sort of consolidating period where it stays about even, then you get into your 40s and 50s and lower and it goes down. Adolescence is the peak time that you put calcium in your bones. The peak time that males and females put calcium in their bones is during their teenage years. There's a linear increase of bone mineral density, which then shoots off during your teenage years, and the majority of bone is put into your bones by the middle of your 2nd decade. 2nd decade means your teenage years. Only a little bit more is gained by your 3rd decade of life. That's your 20s. So think of it like a bank. You're putting money in the bank in your teenage years. It's influenced by nutrition and exercise and the hormones. And if you have imbalances, you can either not put the calcium in, or you can even lose calcium. And we have this fancy x-ray that we tested on. So the majority of women with anorexia have bone loss. Over 50% have full-fledged osteoporosis, even for the adolescents. Not for bulimia. Why? Well, again, I mentioned decreased bone formation, not putting calcium in the bone, and even some loss of calcium from the bone. And all those factors are involved: their nutrition, their calcium, their exercise, but also their hormones are out of balance. I mentioned that. And that contributes to has a big contribution to their osteoporosis. So there are concerns that this might be irreversible. So we check it with this test, the DEXA scan, fancy x-ray. And primarily for treatment, they need to eat. So if you have a patient with anorexia and they eat and they get to a normal body mass index, you study what that is, body mass index, then that's the best thing they can do for their bones. There are all sorts of other things we can do. We used to give them all birth control pills, but we don't usually do that now, and there's some experimental things, but there's no particular answer to that question. And that might be, one of the irreversible legacies of having anorexia as an adolescent, is having poor bone density as you go on in life. For the most part, when we treat the patients, they eat. Sometimes we'll use a nasogastric tube. That's a tube that we put in their nose into their stomach, but very rarely. For the most part, we just structure it so that they eat better. You have to start slow and then go up very slowly each day. And inpatient weight gain, we're usually looking for about ½ a pound a day. Inpatient. Outpatient, if we get 1 pound to 2 a week, we're pretty happy. And there is a significant risk of refeeding syndrome if you feed them too fast. This is no different than if you have a patient in a famine. They actually learned this when they liberated concentration camps in Germany. If you take a patient who's malnourished and you feed them too fast, it overloads their system and they can get quite sick. So we have to do it very carefully. Well, we're getting into treatment. All we need to do for treatment is medically stabilize them, nutritionally rehabilitate the patients, control their abnormal eating behavior, psychologically treat them, and prevent their relapse. So there you go. That's quite a challenge. And so we use a team approach with therapists and dietitians and physicians and whole team approach, individual therapy, group therapy, etc. There are guidelines in the American Journal of Psychiatry that have been published. It's clear that the patients have to have some medical stabilization and eat something before they're going to make a lot of psychological progress. If you have a patient who is, again, 5'8" and 80 pounds, they're psychologically depleted, and they're not going to make a lot of insights in psychotherapy if they're that malnourished. They really have to kind of start to eat, and you can work on therapy issues. Because many of the psychiatric problems are really the result of starvation on the nervous system. I'm going to mention this interesting study called the Minnesota Starvation Study. This is a little bizarre, but this was in the military in 1949, 1950. The military took about 50 to 100 men who were quote-unquote volunteers, and they sent them to Minnesota in the winter, which is torture enough, and then they starved them for 6 months. So these men who were picked for their physical and emotional health were starved for 6 months. They lost 50, 60 pounds. And then they studied them during that time. And when they came out, they were depressed and they were anxious and they were, all these obsessive and binging and purging. And they sort of generated eating disorders in these men by starving them for that time. Now, the ethics of that, you could argue, but that was a famous study called the Key Study, Minnesota Starvation Study. Well, if patients are very sick, we might hospitalize them. Dehydration, electrolyte disturbances, acute food refusal, uncontrollable binging and purging. Sometimes we'll hospitalize patients. Inpatient, we'll medically monitor them, we'll do contracts, and we'll work with them. Insurance issues, the average length of stay for anorexia 15 years ago was 4 to 5 months. Average length of stay now with the insurance stuff is about 3 weeks. So it isn't that they're making that much progress in 3 weeks, it's that the insurance company kicks them out. So we fight with insurance companies all the time. If anybody works for an insurance company, I apologize. Outpatient care, I mentioned group therapy, individual therapy, family therapy. We have day programs, and we have all these different things at the Med Center. This is an important point in terms of ideal body weight. Ideal body weight is a misnomer. There is no ideal body weight. We're looking at the average weight for their height. Let's go over here. Now I'm a lousy drawer, but what's that? That's a bell-shaped curve. That's supposed to be in the middle, okay? So ideal body weight is really just average body weight. I have to pick some number. I have to have some number to think of it. And I know that not everyone's going to be average. Some people weigh more, some people weigh less. But you'd like to be sort of in the ballpark, okay? So this would say be 10th percentile. So anorexia is 15%. Hospitalization is 25%. So we know to have their menstrual periods, they need to be at least in here. So our goal is to get them at least there. They don't have to be here, but I have to have some number to use to calculate. So there are tables which tell me what the average body weight is for teenagers. If you have a 17-year-old who's a certain height, female, I can tell you what the average body weight is, then you can calculate the rest of the bell-shaped curve. Does that make sense? Nothing miraculous about it. It just gives me some type of number to think about. And there are some for adults as well. But again, our goal is resumption of menses. Fluoxetine has been shown to be helpful. In some patients, that's Prozac. No miracle, but it's been helpful. We use some other medicines too. Prozac is very helpful in bulimia at high doses. There are some other medicines we use too, but probably the drug of choice is Prozac. But there are other medicines that we use. The vast majority of teenagers with anorexia really do very well. Really very much recover, probably up to 85%. Now, if I have a woman who's 35 or 40 years old who's had an eating disorder for 20 years, that's a different story. It's harder to change. But the kids, the teenagers, and the young adults do really very well. It said there about crossover. A significant number of patients, as they're recovering from anorexia, will flip into bulimia. It's not uncommon. Some patients don't do well. There's no magic here. For bulimia, again, if you look 5 years later, probably 80% are in some type of recovery, with around 20% still meeting full criteria for bulimia. But still, 80% are doing pretty well, although a bunch of those have had some relapses, and a little bit better, and some relapses. About 50% are completely recovered. But still pretty good statistics. So, finishing up, then you can ask questions, hopefully. We live in a culture preoccupied with thinness, which is really exacerbated by the media. Places a large burden on teenagers in our society. Some of these pressures can interact with other biological and psychological issues to produce an eating disorder, but the vast majority of teenagers and young adults do very well with treatment. Thank you. So I have left 15 or 20 minutes for questions, so that means you have to have lots of questions. Yes?
How many cases do you think you see a year?
We see 30 new patients a month. So in a year, we have outpatient programs, we have day programs, we have hospitalization programs. In terms of current patients and new patients, hundreds. But we see about 30 new patients a month. And then there are other patients that get better and we discharge them. Yeah?
I've been in the first medical for 6 months in the outpatient program.
Mm-hmm. Sure. Yeah, we see lots of patients and stuff. And again, not everybody is desperately ill. We see a lot of patients who have some issues. We treat them, psychologically treat them. They're better. Yes?
The youngest patient you saw?
Yeah, there are a significant increase in young children with eating disorders. Probably the youngest we've seen with full-fledged anorexia is 8. 8 years old. 8, 9, 10-year-olds. The groups that are, not the biggest groups, but the groups that we notice an increase in are young children, middle-aged women, 35, 45 years old, popping up with an eating disorder, no previous symptoms, and males. Those are kind of the things that are changing. Yes?
Who usually brings the patients to their different cells?
Well, the teenagers, no. I mean, most of the teenagers don't want to be there. So their parents bring them. They're sometimes referred just by their parents. Sometimes they're referred by their primary care physician. Sometimes they're referred by school, by high schools or colleges. The adult patients bring themselves. I mean, if someone's 30 years old, I have no authority over them. They want to come. If you don't. I mean, I have no authority over them, and their parents don't either. So, but sometimes they're sent in by their job or something like that. But the teens are usually brought somehow, by their parents. And most of the teens aren't so thrilled to be there, but eventually we try to get them warm over. Yeah.
I had anorexia twice. I went through 2 bouts. I was
Yeah.
26 and 31. Does the heart thing bothers me? Like I still today have like a rapid heart rate and take anxiety medication. Could that be brought on, and is that correct?
Well, it's impossible for me to comment on your medical history because I don't know your medical history. We do see it. We see adult patients as well as teens. I mean, my oldest patient is about 50. So, but most of the time, the cardiac damage will be reversible, but it's not always. Ipecac would be something I'm particularly worried about with patients. But most of the time, the cardiac would be reversible. But there are lots of different reasons why someone can have a fast heart rate. So it's hard for me to comment on the particulars. Yes?
How often is the height weight average updated? Because I would think that 20 years ago, people who are 12 don't weigh the same amount
Yeah.
as today.
It's actually not updated. It's old data, like the 60s. And it's just the best data we have. So I have to tell you that the data is pretty old. Also, the data is not culturally competent. The data was collected in the 60s with, Caucasian middle-class kids. And so different ethnic groups, it would be different. And so we don't really have fantastic data. But again, I don't put that much store in it. It just gives me some way to orient my thinking. But I don't expect everyone to be 50th percentile. I just need to have a 50th percentile. But some people weigh more and some people weigh less. And I don't give patients a goal weight. I very rarely will do that unless they really push me. I just say, you know what, if you're eating well and you're not vomiting and you're having your periods, I'm pretty cool. I mean, if you're somewhere in the normal range and, everyone's a little bit different. So some people weigh more. That's fine. And some people weigh less. Yeah.
Is there, if people who are amenorrhea,
Yeah.
does that affect their ability to have children in any way?
Good question. If they're not having so the question is, if they're not having their menstrual periods, does it affect their ability to have children? Obviously, if they're not having their menstrual periods, that means that they're not ovulating. So they're unlikely to get pregnant then. Although, an important point, patients cannot use anorexia as a form of birth control. So, let me finish. So that, some women have said, well, they'll have sex, they're not going to get pregnant, they'll be fine, except, their body didn't read that chapter, and that month they ovulated. Whoops. And then they got pregnant. And the sick, pregnant patient with anorexia is difficult to treat, because you're talking about gaining 35 pounds. And they don't want to gain 35 pounds, but it hurts the baby if they don't gain 35 pounds. So that's very difficult. So they cannot use their eating disorder as a form of birth control. The teenagers, if they're not having their periods and they're not ovulating during some of their teenage years, and then they recover, I would expect their fertility to be perfectly normal. So when they go into their 20s and 30s, their fertility will be perfectly normal. If I have a woman who's 25, 30, 35 years old, who hasn't had their menstrual period for 20 years, no, it's probably not going to be normal. But for the short term, for the teens, if they recover, there's been no evidence of any long-term effect on their fertility when they've recovered. Does that answer your question?
Do they have problems losing the weight or getting enough weight when they're pregnant?
Well, if they've recovered, then hopefully they'll feel comfortable gaining the weight. But that's always an issue. They don't have problems losing the weight, but we have had adult women who've been pregnant, had a baby, and then lost the weight really fast, and it threw them back into their eating disorder. And the idea is that it's complicated, but you have this serotonin level in your nervous system. Serotonin is made from what? Do you know what serotonin is made from?
I thought it was a neurotransmitter.
It is a neurotransmitter, but it has a certain amino acid base. Do you know what that is?
Oh,
Tryptophan. You know what tryptophan is? Tryptophan is an essential amino acid, if you've heard that term. It's an amino acid that you have to eat. Your body cannot make tryptophan to make the serotonin. So if you're protein deficient, then you don't have enough tryptophan to make the serotonin, and you can get really depressed and spiral down into a eating disorder. So the idea is that these people, one of the things we'll caution somebody if there's a recover from anorexia, they really shouldn't go on a crash diet for any reason, because they can just throw off their serotonin and then spiral right downhill, and then they have to kind of get back again. So it doesn't mean they can't lose the weight after the pregnancy, but it depends on how they do it and how fast they do it. That answer your question? Mm-hmm. Yes?
You mentioned wrestlers. Do you see a spike like during the season and then a drop off afterward?
I have to tell you, most of the wrestlers I don't see. I see the patients who don't get better after wrestling season. Nobody comes to see me during wrestling season. But there are some, most of the kids, although it is bad for their bodies to do that restricting and binging and stuff, but most of the guys, when they finish wrestling season, don't keep doing it. But the ones who keep doing it, that gets everybody upset, and then they send them to me. So I have to tell you, I don't see them during wrestling season, because they all do it. So, yeah.
What, on average, when people recover, how is their weight then? I know it's obviously they weigh more afterwards, but is it, high or?
It could vary. Some of the patients have a low normal weight, but there is that flip for some patients from restricting to binging. So some of the patients end up a little overweight, because that hunger and fullness cycle in their brain is just not there. There are hunger and fullness centers in your hypothalamus, in the gland in your brain, that regulate that. And it gets out of whack, it gets out of balance, and sometimes it's hard to get back into balance. And so that's why people sometimes flip from restricting to binging. So sometimes they're a little overweight. Yeah?
Do majority of your patients, when it comes to do they know the health defects, what's happening to them, anorexia and?
Most of the patients, especially if they're teenagers, do not. And they're not in the mood to listen to it. There's no evidence that, knowledge is very useful, but there's not a lot of evidence that my giving this talk to my patients is going to make any difference, because it's emotional. It's not a logical illness. If you're thinking logically, you wouldn't starve yourself till you weigh 70 pounds. Or you wouldn't keep vomiting. But it's not a logical illness, it's emotionally driven. So part of what we do is an educational process, but that's not enough. You have to have therapy and counseling to get at the emotional aspects that are psychologically triggering the eating disorder. Does that make sense? Yeah. So that's why we have our team. So I spend a lot of time on these issues and their physical things, and then they have a dietitian who will go over their meal plan and do a lot of this nutritional education. But that isn't enough. There's this whole other side to it, this whole psychological side. So that's why they need counseling, some type of therapy, whether it's family therapy or individual therapy or group therapy, to work on the emotional aspect, because everything gets hooked together. Yes? Yes. There is a significant genetic trend. It's very complicated. No one knows exactly what that is. So it's not always that their mother had an eating disorder, but we do see that sometimes, where it tends to run in families. It might not necessarily be a close relative. Maybe it's a cousin or something. But it has to do probably with the serotonin. I had some genetic slides, but they're complicated. It has to do with the serotonin and other neurotransmitters. Serotonin is just the one that's best studied. But there are other neurotransmitters, and it has to do with different receptor genes and stuff like that. But the idea is that there's a genetic predisposition towards having a problem with serotonin, and for some people it goes off in that direction. Yes?
Are there some foods that the body will not ever be able to digest again?
No, that's not true. You can have people who are lactose intolerant, but there's no evidence that the eating disorder itself would mean that you can't digest food. If you eat better, then your body will absorb it. That's why, to be honest with you, I never use intravenous nutrition. If I have someone with cancer, you can put a big catheter in their vein and give them nutrition through the vein. It's called hyperalimentation, but it has a lot of side effects. These patients, their guts work. If they put food in their intestines, they'll absorb it. So most part, they eat and they drink. If we have to, I'll use a tube, although I rarely do that. But I never had to do the vein. For the most part, they will digest food well. Now, it can take a long time for their stomach and intestines to gear up because they're slow, they're sluggish. But they will gear up. Yes? Oh, I don't know.
Have you ever seen anyone like if you were for 7 months and you're fed through a central line for 7 months, is that part of your body?
Yes.
Damage?
Yeah, I mean, the hyperalimentation, if you're fed through the line, can cause liver damage. So they have to monitor that very carefully. So, I mean, there have been people successfully fed, for years like that, but it has to be...
I was fed for 7 months through a central line. When I was pregnant, I couldn't
Right.
drink anything. But is there, is there effects afterwards? Do you see that? Hard to get back in a regular routine of eating?
I'm sure. Although I have to tell you that's a little bit beyond my expertise. I don't usually do that. But it would be hard to, your stomach and intestines would be slow and they'd have to gear up. The hyperalimentation itself can cause liver damage, although they watch for that. And they check your liver function tests and things. The doctors would be watching that. So, but there are lots of patients with lots of medical conditions that do that. But I don't usually find it necessary with my patients. Yes?
Children nowadays getting diagnosed with like ADD and ADHD and be putting on Concerta and
Yep.
Abilify and Tara, all things that affect their serotonin and neurotransmitters. Do they run a higher risk of developing eating disorders? Because I know most of those pills restrict their diet.
The question was about the ADHD drugs. There's no evidence that having treatment for ADHD will lead to an eating disorder. However, we have seen a lot of patients for nutritional consultation while they're on the medication because it can decrease their appetite. And so then we have to find different ways to adjust the medicines so they can eat and maintain their weight even though they need the medicine for their hyperactivity. So, it gets complicated. Adderall is probably the most appetite restrictive. Strattera, which isn't a stimulant, is the least. Concerta is kind of in the middle, the Ritalin compounds. But I see those consultations a lot, but it just doesn't trigger a classic eating disorder.
Is it safe though, like to switch them constantly to get to maintaining weight?
Yeah, we switch them all the time. The idea is to try to find a balance between an effective dose and effective medication for their ADHD, having them eat and grow. So we often participate with a psychiatrist in that. Yeah.
You said that the point that you want to get women to is to get their menses back.
Right.
What would be that point for males or people who doesn't have their menses?
Very good point. At least 10% of their ideal body weight. So that within the 10th percentile for their ideal body weight. So it becomes more arbitrary. So for women who will be having their ovulation and their menstrual cycles, I have a biological marker for their recovery. It's actually not just menses, it's actually ovulatory cycles. Now, it's not that easy to demonstrate ovulation, but they're having regular cycles, we assume they're okay. But for males, it becomes a little bit more, I want you to get into a certain range. I still don't use a number, but in my head, I have more of a number as opposed to a physiological sign. Good point. Yeah?
They said people that don't eat a lot and then when they do eat, they get full really fast.
Yes.
Is that like an eating disorder or anything? Is that bad?
Well, if you're not eating well, then your stomach and intestines slow down and become sluggish. So then when you eat well, you feel really full and you can almost feel sick. So it's not great because you feel uncomfortable. So you have to eat well to kind of get past that. You have to keep eating well. There are some medicines we can use, although everything has side effects. But for the most part, their stomach and intestines will gear up and become less sluggish, although it can take several weeks or a month or so. Did that answer your question? Yeah. Yeah.
Are eating disorders more common than people being obese, the overweight factor?
Actually, obesity is probably more common than clinical eating disorders. But, it's very interesting. We live in a very difficult culture, where you have a big problem with obesity among young people and in the schools, and a lot of different efforts to try to prevent obesity and the consequences of obesity. Yet you also have people with anorexia and bulimia. It's kind of hard to find in the middle. There was someone who gave a great lecture at one of the academy meetings that talked about our toxic food environment, that the way food is marketed in our country and the way a lot of it's very heavily processed food is made and heavily marketed is really really bad for kids and teenagers in our society, so that you end up with one or the other type of problem. I'm concerned myself about what I think is a little bit of a heavy-handed way that the high schools are approaching it, where they do the BMIs and they send home the report card and stuff, because we have seen kids who basically, the health teacher said I'm overweight and I shouldn't eat fats. Fats are all bad, which is not true. And thus they stop eating and they lose 60 pounds and they end up in my clinic. So, most kids won't do that, but a few will, and it's a lot of kids in Pennsylvania. So we worry about the way it's being addressed. So we're kind of working with that. As you've learned in your classes, you need a balance between carbohydrates, proteins, and lipids. I like to say lipids so I don't have to say fats. So carbohydrates, protein, and lipids. And the American Heart Association diet for people with heart disease is 20% of their diet being fat or lipid. For non-heart disease, you're looking at probably 25 or 30%. Now, I'm not talking all saturated fat, and I'm not talking trans fats, which are bad, but you need fat in your diet. So some of these kids eat like 3% fat. Their diet is so relentlessly, basically they eat like lettuce, and it's so relentlessly low in protein and other nutrients that they're getting absolutely critically malnourished. And they're misinterpreting, somebody saying fat is bad. I understand that too much fat is bad. I'm not asking you to supersize me at McDonald's here. But some lipids in dairy and in olive oil and in nuts, it's very good for you. And if you don't eat that, you get depleted. And you get really, very, very critically ill from that type of depletion. So it's the balance. They're also misinterpreting, diets that are meant for basically 65-year-old men and women with heart disease for a growing 15-year-old. The nutritional recommendations for a 15-year-old active cross-country star are different than for a 65-year-old man or woman. It's different, yeah.
I read somewhere that Asian Americans and Caucasian Americans tend to have more issues with anorexia and bulimia than African American women.
Mm-hmm.
Is that still true?
That's probably true. We do see, it's not a rule, but that probably is true. For African American women, we tend to see more, if we're going to see eating problems, we tend to see more binge eating than we will. But I have seen African American girls with anorexia, but probably not as common if you're looking at statistics. I'm not sure, and that's actually being studied exactly why, but it's probably true.
Do male and females recover better?
There's not a lot of literature on that. The medical problems will be pretty similar. In my personal experience, I find the boys recover more easily, for the most part. They tend to have somewhat less psychological issues. Guys, basically eat, okay. And if you teach them that it isn't good to be restricting, that it's not great for their wrestling or their basketball or their weightlifting, and you work through that they recover a little bit more easily. But I have to tell you, that's probably my anecdotal experience as opposed to the literature. And I have seen some very, very sick males as well. So.
And as far as the age group goes for males, do you find they're younger or older?
I've seen all. I have seen 40-year-old men, and I have bulimia, and I have seen an 8-year-old little league pitcher. So we've seen all of that.
Another thing in regards to that, I read something where the males who tend to have these eating disorders also have issues with homosexuality and
Well, I wouldn't say it like that. I would say that if you look at a group of males with eating disorders, you'll see more patients who are gay than in the general population. And that might be that gay males tend to have a little bit more preoccupation with their body than heterosexual males. But it's not that dramatic of a finding. Yeah?
I was just curious, does it have anything to do with, like, man's ability to have children? Like, does it have an effect on that?
No evidence of that. I've not seen that. Any change in male fertility. Overall, if you're critically malnourished, it isn't good for your fertility, but I have not seen any literature about. That's an interesting question. You've had some good questions. Males with eating disorders and infertility. I've not seen any literature on that. I haven't seen that many adult males that are looking to have children that I would have any personal experience with. I don't think you can use it as a form of birth control, however. I don't think someone can use that and not use condoms, but I haven't seen any literature. Probably have time for 1 or 2 more questions. We're burning out here.
Once they leave the clinic, do you find that they sometimes regret?
Sometimes. But, I mean, most patients, you know, we discharge them from a clinic and they're off and they do great. But sometimes people relapse for various reasons, you know, either personal reasons or psychological reasons. So sometimes relapses, but that doesn't mean, you don't lose all the progress you made if you have a glitch and a relapse, and you kind of hopefully can get back on track and go on with your recovery. It is very much of a recovery, not a cure. A cure implies you have a strep throat, I give you penicillin and I fix it. A recovery means that the primary responsibility in getting better lies with the patient, or the patient and the teenager and their family. But we have tools, lots of different treatment tools. Yes?
Do you ever feel that giving seminars like this or pamphlets or having commercials would actually put the idea in some people's heads that they need to do?
Well, I'm doing this for your class, you know, but it isn't usually recommended if you're going to do an eating disorder prevention effort, which I don't think this is. I mean, this is part of your classroom studies to learn about eating disorders in your nutrition class. Am I correct? Yeah. So, if I was going to do a eating disorder prevention program for your campus, this is not what I would do. What I would do if I was going to do an eating disorder prevention program is talk about nutrition, which you already do. I would talk about the media. I would try to deconstruct the media a little bit and show the media manipulation that they do, you know, in terms of the models and it's not just airbrush, but the computer, if you know anything about Photoshop on a computer and stuff, I mean, it's all computerized. And we would deconstruct the media some. We would talk about coping skills and not using food, either eating too much or eating too little as a way to cope with problems, and good coping skills. So we would do not just one visit, but, you know, a weekly thing for 10 weeks on various aspects of nutrition and the media and psychological issues. And you don't have to, you don't have to develop that unless you're doing research on this. I mean, there are eating disorder prevention programs that are available for middle school, high school, and college. If you want to look up somebody, Dr. Michael Levine, no relation, but Dr. Michael Levine is a psychologist at Kenyon College in Ohio, who I know very well. And actually, he was at Hershey giving a talk for us a couple months ago. And he does eating disorder prevention research. And he's written a book on eating disorder prevention, published articles. I mean, there's a whole literature on how to do that. So you don't have to start from scratch. But this is not the way I would do that. And so if I wouldn't go to a high school and give this lecture. But I figure for your class, that you want to know this for people's information, you know, for your academic learning. So I hope I don't trigger any eating disorders. Now you've made me worried. But this is not the way I would do a prevention effort. Anything else? Great, thanks. I have cards back there with my number, my email. You know, if you have questions or whatever, email me. I'll try to answer.